is typically around 5 or 6. So we've been enrolling mostly younger boys. There are boys that don't go on steroids even after that. So that is the choice of their parents and physicians. So what we will do is first look at efficacy in that age group. And as we learn more, then we will be able to expand studies. Once we've seen that there's efficacy, then we can move into the ambulatory boys. We know that it's very important to also look in the non-ambulatory young men. And that's another group that we will be looking at as soon as possible. Is that it?
Yeah, so Thomas?
Just one comment. There's no one single steroid regime that is currently used. And you know that there was a recent publication by Professor Griggs in the United States who summarized that currently across the Western world, that is US, Canada, and Europe, about 30 different regimes are currently used. So I think the first step really is to try to harmonize the use of steroids, although there's efforts ongoing. And in addition, there will be maybe other drugs coming along that may have more advantages over the standard steroids. But still, currently, this is a recommended standard of care. Nevertheless, there's no unique guidance on how they should be used. And there's still a lot of confusion about, or variability on how the steroids are used.
Thank you. So there's a question in the front. Oh, no.
Scusate, volevo chiedere per lo studio di CAT 1004 se poteva potenzialmente essere applicato anche alla Becker, visto che normalmente nella Becker non viene mai prescritto l'uso di cortisone, penso più che altro per gli effetti collaterali e se un domani ci sia una molecola più sicura possa essere, diciamo, prescritta anche per la Becker. Grazie.
Right now, CAT 1004 is not available in any country. It's an investigational agent. But I think that your point about Becker's patients is an excellent one because steroids have side effects in that population, and this would avoid that. So it's a very good suggestion.
So maybe the same question also to Eric and Thomas. So would your drug also work in Becker patients?
Yeah, I think, as I mentioned, glucocorticoids have a huge number of indications, and in many of those indications, they're not used like Becker because it seems the side effects overwhelm the efficacy, so the balance of side effects. But yeah, I think all these drugs have a lot of potential for Becker and other inflammatory disorders, and certainly for VBP15, Becker, and also like inflammatory bowel disease in children who also have severe side effects are on the plan to develop.
Yes, and we have studied our drug in patients not taking steroids, Duchenne patients not taking steroids, which is resembling your situation where you said Becker patients are not taking steroids. We have no data to make any claims, but there's no reason to believe it may not work, but we need to investigate that.
Thank you. So now, really the lady in the front, she's been waiting for quite a while, so I suggest she takes her question now.
Thank you. Good morning. I would have a question about VBP15. As you said, glucocorticoids without side effect, that's quite a big boom for most of indications. Did you run any trials regarding other diseases than Duchenne, or is Duchenne the first trial?
We've run many preclinical models, so like as in mice. So mice with asthma, with multiple sclerosis, with arthritis, with inflammatory bowel disease. And VBP15 works as well or better than glucocorticoids in each of those mouse models. Now we're bringing it forward in Duchenne because of you guys, because it's all been supported by the Duchenne community. And actually it's important to make sure that Duchenne is the primary indication, but there could be other indications.
Can I add to that as well? The Muscular Dystrophy Association supported our preclinical studies 5 years ago. So that, again, really pushed us into that, as well as all of the work that's been done to understand what the regulatory path is. So that's all been very important to us in deciding to go forward with Duchenne as the first indication.
Okay. Question? Yeah.
una domanda per il VBP15 e volevo capire qual è la fascia di età che diciamo, viene decisa per l'inclusione nel trial, e poi volevo capire per quale motivo non si sia riusciti a evitare il placebo appunto nella definizione dei trial, considerato che comunque sia per i ragazzi di MD alla fine il cortisone in questo momento è l'unico trattamento possibile, quindi perché gli antiregolatori hanno per forza imposto la presenza del placebo e se si può ridefinire questa cosa, chiedo. Grazie.
The age range, the first question is, as with CAT 1004, we're targeting the younger subjects before they would normally necessarily take glucocorticoids because, as was pointed out, it is standard of care. So we're in the same 4 to 7 year old steroid naive age range for the initial trials. What often is done then is you do safety trials in an expanded age range, and so that's encouraged by both EMA and FDA. So we're planning to do in both younger and older patients a safety study to make sure it's tolerable, you get the same pharmacokinetics, and that could extend the labeling if it's shown safe and effective in the 1 to 4 year olds. So we have, the EMA also requires you to do a pediatric investigation plan, so a PIP, and so there you should design trials between newborns all the way to 18, and that's required of every drug going through the EMA and through Europe. So we've already submitted that PIP and have trials planned in every age range. But we want to start where we think you put your best foot forward, which is, the younger 4 to 7 year olds. Your second question was? Placebo. Thanks. The 2A does not have a placebo, so the first 24 patients will all be on drug, and that'll be long-term 6 months, and with a 6-month probably extension study after that. So the problem with not having a placebo is that you need something to argue against placebo effect, that just doing the 6-minute walk many times, you can get good at the 6-minute walk test. And then the question is the drug working, or are the children getting good at the 6-minute walk test? So the biomarkers can help argue against placebo effect. So in other words, if you see acute change in blood that supports your clinical outcomes, also as CAT 1004, MRI, they're all biomarkers which everybody's trying to use more of. So hopefully we may, at the end of the 2A extension, be in a position where we have a compelling case even without a placebo. But regulators still would prefer a placebo arm, as you've heard through many trials. And so the 2B through Europe, at this point, plans a placebo arm. But again, just for 6 months. So then those placebo would transfer to the active drug after 6 months. And remember, we're at a young age range when they wouldn't be necessarily considering steroids to begin with. So it's a balance, it's a hard balance to reach. And maybe after we do the 2A study, the data might be compelling enough that you could go back to the regulators and say, do we really need a placebo going forward? I think all these programs have these interactions with the regulators to try to work the best path forward.
And maybe I can add, so we had that meeting last year with the regulators, and we of course also brought up the problem of placebo, not just for VBP15, but in general. Do we really need placebo? Can't we use the natural history? And I think for now they were very clear that you need to do placebo. So you can do a trial without a placebo group, but then your drug will never be approved. So that's also not helpful. So we're communicating with the regulators, and hopefully in the future we can do without. But I think at the moment they force us to do the placebo-controlled trials. So question over there.
Si parlava del cortisone e della sua importanza nella somministrazione fin dalla giovane età del bambino. La domanda è: da quanti anni è indicato e quali sono le sintomatologie iniziali che sono utili per cominciare a usarlo? Grazie.
Yeah. So I'm going to refer this to the clinicians on the end of the table.
Ma allora, non c'è una sintomatologia iniziale, nel senso che normalmente ormai c'è un po' non esiste ancora, c'è un po' di discordanza. Adesso la dottoressa Sansone prima parlava di questo trial che sta, diciamo, finendo, che ci dirà qual è il cortisone da usare, la posologia e il timing. In linea di massima ormai diciamo, i 13 centri italiani diciamo, siamo arrivati alla consuetudine di iniziare il cortisone intorno ai 5 anni e ci sono dei lavori insomma, ormai negli ultimi anni che insomma, sostengono, comunque hanno sempre più convinto nei clinici sull'idea di iniziare il cortisone tutti i giorni a 0,9 mg per chilo e il prednisone, insomma. Questo più o meno è diciamo, la maggior parte dei clinici italiani. Non c'è una sintomatologia diciamo, che ci fa pensare che quel bambino la deve usare piuttosto che un altro. Insomma, si cerca di utilizzare diciamo, più o meno tutti, proprio per avere degli standard di cura, per avere uniformità di lavoro, uniformità anche di dati poi, no? Da poter utilizzare poi, anche perché ormai sempre più, diciamo, se un bambino deve entrare in un trial, come ha potuto vedere in questi giorni, tutti i pazienti che entrano nei trial devono avere il cortisone stabile da almeno 6 mesi con la posologia insomma stabile, adeguata al peso e poi diciamo durante il trial puoi solo adeguare al peso, non puoi cambiare tipologia di somministrazione, per cui sempre di più si sta cercando per fortuna di uniformarci, no? Agli standard di cura tutti allo stesso modo.
Sì, volevo aggiungere che appunto ci sono questi lavori anche del gruppo inglese di professor Montoni, Valeria Ricotti, insomma, che mostrano che effettivamente già iniziato molto presto, 4-5 anni, i bambini vanno molto meglio rispetto a chi l'aveva iniziato più tardivamente. Parallelamente un grosso lavoro che bisognerà fare, l'avete sentito forse chi c'era venerdì, no? Su quello che è modificare gli standard di cura, perché ovviamente l'alimentazione, il peso, no? Tutti gli aspetti, le complicanze diciamo, legate a quello, l'uso del cortisone anche molto precoce, ovviamente bisognerà stilare insomma, delle nuove linee guida, delle nuove indicazioni anche che hanno a che vedere proprio con poi l'alimentazione di questi ragazzi, il discorso dell'osso, no? Della demineralizzazione dell'osso, insomma, quindi bisogna parallelamente un po' riassestare un po' anche gli standard di cura e il modo in cui vengono seguiti.
Okay, question in the back.
Buongiorno.
Oh.
Pronto? Io volevo sapere, per tutti quei bimbi che adesso sono in cura steroidea, che cosa succede qualora le vostre molecole dovessero essere approvate dalle autorità regolatorie e quindi venissero poi distribuite ai bambini. Chi è invece già in cura cortisonica, che cosa succede? Se possono passare oppure no?
That's a very important question. I think that we have very good trials showing what happens when boys go on steroids. We don't have as good trials, or we don't have trials showing what happens when they go off. So that's going to be not the most straightforward for study design. It is, so for the initial studies, we're looking at boys that are not yet on steroids. But it's going to be very important to also look at that transition because boys are already on steroids. So you're absolutely right. That's something that we need to look at in our development plan.
And for our drug, I can say that we have studied in a phase 3 trial patients not taking steroids who had stopped taking steroids for side effects, for instance. But the new trial that I've introduced will be targeting the co-medication between steroids and our drug.
A key thing with taking steroids is the tapering off of steroids and paying attention to the potential for what's called adrenal crisis, so that when you take glucocorticoids, the adrenal function is suppressed, which can become a problem in acute illness, injury, or surgery. And in those situations, the adrenals need to make more cortisol to help the body compensate for stress. So that should always be watched in all Duchenne children all the time. If there's any acute illness, surgery, or injury, to pay close attention that there is not any signs or symptoms of adrenal crisis, which is like lowering of blood pressure, hypoglycemia, lethargy. That will be very important as we transition between these different drugs. That I think it's possible you can wean off glucocorticoids and use these other drugs either alone or in combination. But everybody should become more sensitive to what adrenal crisis looks like because that can be an issue that's under-recognized in Duchenne muscular dystrophy even now.
Okay, so I just heard we have time for 2 more questions. So there's one there, and I think Eugenio had a, no? Filippo, okay. So we have one in back, and then Filippo has the last question.
Sure, I had a question for the CAT 1004. Interestingly, you're one of the few companies who have put imaging as your primary outcome. So I wanted to ask what led you to make that decision as a company. I appreciate it's your early phase work, but what led you to make that decision, and also what feedback have you had from the agencies around the acceptability of that?
Yes. The reason that we chose imaging, and the reason why Professor Lee Sweeney came to us and said, we have a biomarker that can see changes early on and do it objectively in a way that will then allow you to move to a larger study that can be a registration study. So it's really the urgency of being able to move forward that has focused us on MR as a primary endpoint. We can see that in an objective way with a small number of boys, and that will allow us to then very quickly move on to the registration study. So that the feedback that we have gotten from regulators has been very positive on this. They would, and they have looked for this from many companies to understand what the effects of MR are because of the objective nature of it.
Filippo.
Come associazione, almeno in Italia, molte delle famiglie premono per fare in modo che sia accelerato l'accesso almeno verso alcuni farmaci che sono più apparentemente sicuri e quindi magari possono essere utilizzati prontamente. E quindi la domanda era se è possibile cominciare a pensare a una 648 per esempio per l'Italia per il Debenone, almeno insomma, che dovrebbe avere dati sufficienti.
Well, obviously, that would be of interest, and I believe that the initiative has to come from the physicians in the country. As a company, we have to stay back, but I support that idea that you have there. We have, just to say, I mean, the drug is already approved, not for Duchenne muscular dystrophy, for another indication in Europe. So the regulators have already approved it. And now we are going forward and do what is called a variation. That means we try to add the second indication to the label. This is a process that will take probably a year altogether from now to early next year until the regulators have approved it. But in the meantime, there would be a possibility to make it available to patients in certain countries where L648 or ATU approvals are possible.
Sì, infatti come associazione ovviamente ho spiegato alle famiglie del nostro gruppo in Italia che la preferenza è quella di condividere con la company la disponibilità a partire con la 648 proprio per la necessità di avere dati che supportino uno sviluppo veloce del farmaco invece che magari ritardarlo, quindi il fatto di sapere che la company è pronta ci spinge a fare in modo che il network italiano dei clinici supporti la nostra richiesta. In Italia la lettera può essere scritta anche dalla nostra associazione, ovviamente deve essere supportata dai clinici e faremo in modo che i clinici ci supportino in questa nostra richiesta. Quindi per le famiglie che lo chiedevano questa è una nostra call to action, ci mettiamo al lavoro.
So I think that was a very good last question and comment. So thank you all for your active participation. Thanks to all the speakers for presenting and of course their willingness to answer all your questions. We now have a break. We're actually on time, so well done all. It's time for a break. We reconvene at 10 minutes past 11. Thank you.